Hello. Thank you, Dr. Krishnan, for the honor of this invite. And it's my absolute pleasure to be here this morning with all the faculty here to share the stage to discuss an extremely important topic, hyperglycemia in pregnancy. Why should we actually treat hyperglycemia in pregnancy? Let me begin by asking a question to the audience. In your estimate, how many percentage or what percentage of women with pregnancy do you think have hyperglycemia, or what proportion of pregnant women in India have hyperglycemia in their pregnancy? Do you think it's 10%? Do you think it is 50%? Or do you think it is 20 to 25%? So this is data which is from the International Diabetes Federation Atlas, which took a look at the prevalence of hyperglycemia in pregnancy in women aged between 20 to 49 years. While the global prevalence is estimated to be around 13%, an astonishing 27% of women from Southeast Asia have their pregnancies complicated from hyperglycemia. It is an extremely common condition, yes. Probably we are a predisposed ethnicity, but of late there have also been conversations about whether we have been dropping our cutoffs for the diagnosis of hyperglycemia, and is that the reason why the prevalence of hyperglycemia in pregnancy is increasing? So I'm going to today review evidence that is accumulated in the last decade to answer this exact question. Is there any advantage of lowering the cutoffs for diagnosis of hyperglycemia in pregnancy? Is it actually translating into better outcomes for pregnancy for the women, and whether it's altering the outcomes for the newborns because we are managing hyperglycemia in pregnancy better? And there's a lot of data which is accumulated in the last 10 years. So we are all aware what overt diabetes does to an infant during pregnancy itself. There are numerous congenital anomalies that occur, especially if the mother has pre-existing diabetes. I think this is kind of very well established, and I'm not going to step into this zone at all. We all know that overt diabetes has to be treated to prevent anomalies, especially in the first trimester. We also know that the correlation of adverse pregnancy outcomes correlate quite strongly with HbA1cs in the mother itself, with there being a strong log linear relationship as HbA1c increases beyond 6.5%. And that's exactly why we want to reach targets of close to 6.5% even before we plan pregnancy. Of course, not only are we talking about congenital anomalies, we also know that there could be adverse pregnancy outcomes through the duration of pregnancy if blood sugars are not adequately controlled. It could range from abortions in the first few weeks to intrauterine death later on, with macrosomia, neonatal hypoglycemia being other adverse outcomes neonatal in pregnancy that we should be worried about. But the nuances of management of hyperglycemia in pregnancy also is something that we probably need to pay attention to. We all know that nutrients from the mother, specifically glucose, crosses the placenta freely and easily. With excess glucose levels in the mother, it translates into higher glycemia levels in the infant itself, which then leads to increased insulin production from the fetus itself, which could then translate into macrosomia or immediate post-delivery neonatal hypoglycemia. There is also suggestion that exposure to hyperinsulinemia in the intrauterine milieu could predispose the child to obesity and impaired glucose tolerance, and maybe earlier onset of type 2 diabetes as they grow older. So while we are all very convinced about management of overt diabetes, we haven't been quite clear about the benefits or the nuances of management of hyperglycemia in levels which are much lesser than overt diabetes. So a lot of development in terms of knowledge accruement has happened in the last few years, and with that, we have been changing our diagnostic criteria for gestational diabetes in pregnancy as well. So if you take a look, we now following the IADPSG criteria, which is also adopted by the American Diabetes Association, in which we have values which are dropping down to fasting values of greater than 92, a 1 hour value of greater than 180, and a 2 hour value greater than 153. And earlier, the WHO criteria required 2 abnormal values to make a diagnosis, whereas the recent criteria has brought it down to 1. Is there any logic reasoning for this change in cutoffs and change in the number of abnormal values, or are we just over diagnosing GDM? So much of this new diagnostic criteria came after the publication of this extremely important study, which looked at hyperglycemia and adverse pregnancy outcomes, which came out in the NEJM in 2008, which included a large number of women, around 23,000 women, 9 countries, 15 centers. They were administered 75 grams of glucose, and an OGTT was done between 24 and 32 weeks of gestation. What they did was they made a note of the blood glucose levels. If it was less than 105 fasting and less than 200 at 2 hour plasma glucose levels, and they just quietly observed these women through their pregnancy and looked for both fetal and pregnancy related outcomes at the end of delivery. And what were the outcomes that they were trying to look at? The primary outcomes they were looking at was the birth weight. They were trying to look at cord blood C-peptide. So cord blood C-peptide is representative of fetal hyperinsulinemia. They were trying to look at cesarean section. This could be a surrogate for macrosomia, and of course neonatal hypoglycemia in the baby. Secondary outcomes they were looking at was prematurity of delivery, shoulder dystocia, birth trauma, admission to NICU, preeclampsia, and hyperbilirubinemia. So hyperbilirubinemia could be a surrogate for hypoxia secondary to macrosomia in this context. And what they found was quite astonishing. And before we go on to reveal the results of the HAPO trial, I would like to draw the attention of the audience to the levels of the categories they divided the group of women into before studying. So you will see graphs which go from category 1 to category 6 in the HAPO study. And in category 1, the fasting levels were less than 75, the 1 hour levels were less than 105, and the 2 hour levels were less than 90 milligrams per deciliter. So that is really close to normal. That's the point I'm trying to make. And when they looked at the outcomes, the primary outcomes and the secondary outcomes, this is what they found. They found a strong and continuous association of maternal glycemia, be it fasting 1 hour or 2 hour. That's what the 3 different colors mean. When you were looked at macrosomia, when you looked at cesarean section, when you looked at serum C-peptide levels, right? So this is establishing that even at blood glucose levels as low as 75 in the fasting state in mother, you could potentially be altering pregnancy and neonatal outcomes. So all of this remained to be true even after adjusting for numerous other variables which could have potentially altered the outcomes in this context. So that is the basis of why we have changed our diagnostic criteria to one abnormal value of 90 to 180, 153 milligrams per deciliter. But many groups of people have wondered if this has led to overdiagnosis of pregnancy, if we are now getting more and more pregnant women to be branded as gestational diabetes, if we are enforcing monitoring a little severely, if we are now treating them with insulin, treating them with medications a little more. Does this all translate into any changes in outcomes for the child, for newborns, and all of that? And this is a good time to take a look at anything, simply because it has been about 10 years since this data has come out, and now we are here to be able to study and look at some of the metabolic outcomes related to this in children. And there's a wealth of information that's been out now. So this was a publication which came out in 2019. This is a follow-up study of the children who were born out of the HAPO cohort back in 2000 end, which tried to study the relationship between the diagnosis of GDM in the mother and compare it to the glucose metabolism in children themselves. So when you looked at this, they invited all the children who were born out of this cohort to participate, but about 4,000 and odd children aged between 10 to 14 years completed this study and participated in it. They were invited, and the children were administered an oral glucose tolerance test. And what they tried to look at was they divided the children into two groups: mothers who had GDM as diagnosed by the WHO criteria, and others who did not have GDM by the WHO criteria. And they tried to look at the outcomes related to the OGTT in the children as impaired fasting glucose, impaired glucose tolerance, and a diagnosis of type 2 diabetes itself. And this is what they found from this study. Panel A and Panel B are looking at the prevalence of impaired glucose tolerance. Panel C and Panel D are trying to look at impaired fasting glucose. And you can see that in children whose mothers had a diagnosis of GDM according to the WHO criteria had an odds ratio of 2 as compared to children who were born to mothers who did not have a diagnosis for GDM to be diagnosed with impaired glucose tolerance at the age of 10 to 14 years. Of course, the odds ratio was not increased for impaired fasting glucose, but the correlation for impaired glucose tolerance is quite significant, even after adjustment of various confounding factors, including childhood BMI. Also noted that in children whose mothers had GDM by diagnosis, at the age of 10 to 14 years, there was lower insulin sensitivity as noticed by the Matsuda index, which is negatively correlating with it, and also an impaired glucose disposition index. So to conclude, in children who were born to mothers who had GDM at 24 to 32 weeks, 10.6% of children had impaired glucose tolerance and 5% as compared to 5 without GDM, and 9.2% had impaired fasting glucose versus 7.4% who had mothers who did not have GDM. And now this odds ratio was at 1.09 for fasting glucose, but it was 1.96 for IGT, even after adjusting for family history of diabetes, maternal BMI, and childhood BMI. And it also correlated inversely with insulin sensitivity and oral disposition index. So that answers the question that the diagnostic criteria that we have, at least the WHO criteria, is definitely translating into adverse metabolic outcomes in the children. And this is an extremely important finding that we've come up with. But the other question could be that it was 2 abnormal values and now you made it 1 abnormal value. Could it still be that the WHO criteria might be valid? Yes, I do agree. But what is the strength of evidence for the IADP criteria or the ADA criteria? Is that too stringent? Does that also correlate with any adverse metabolic outcomes in the child itself? So we have a paper which has looked at exactly this question as well. This is also from the HAPO cohort, but here what they've tried to do is, instead of dichotomizing the children into children born to mothers with GDM versus no GDM, what they've tried to look at, they've studied the continuum of the maternal glycemia and tried to look at now the childhood glucose metabolism in children. Again, similar plan of action. They invited all the children to come back for follow-up. Roughly 50% of them have come back, and they were given a 75-gram glucose OGTT, the children, and they also were subjected to physical measurements, and they went on to now analyze this data. Again, I'd like to bring to your notice that the same category which was used in the HAPO study is also something that is used here, because this is a continuum. Again, they looked at categories from 1 to 6, starting as low as 75 for fasting, 105 for 1 hour, and less than 90 for 2 hours. And what they found here is, again, extremely interesting. As you see that the maternal glycemic levels are varying from category 1 to category 6. Of course, the red stands for fasting glucose, green stands for 1 hour, and blue stands for 2 hours of the mother during the pregnancy. And now they are trying to look at the child's glucose levels at 10 to 14 years of age. And what you see is as the maternal glycemic level rises, even at levels as low as 75, 90, and 105, you see that the child's 1 hour glucose is increasing, fasting glucose is increasing, A1C level is increasing in sync with the rising maternal glycemia. And similarly, they also looked at the Matsuda index, which is again an insulin sensitivity index. You see that there is a negative correlation with rising maternal glycemia. A similar finding with the disposition index as well noted in the child. So quickly to conclude findings from this paper, the maternal fasting plasma glucose levels positively correlated with the child's fasting plasma glucose, and the maternal 1 hour and 2 hour plasma glucose correlated with the child's all three sugars, including the A1C levels, and also inversely correlated with insulin sensitivity. And all of these associations were independent of maternal BMI or childhood BMI. And across increasing categories of maternal glucose, the frequency of finding IGT and IFG in children was higher. So these are extremely crucial findings, which kind of strengthen the evidence base for um, aggressively screening for hyperglycemia and aggressively treating gestational diabetes in pregnancy. And in the last decade has been a revelation when it comes to area of knowledge in this particular area. So quickly to summarize, why should we treat hyperglycemia in pregnancy? Because we learned from the HAPO study that there is a strong and continuous association of maternal glucose levels below those diagnostic of diabetes with increasing birth weight and increasing cord blood C-peptide levels in children who are born to mothers with rising glucose levels. We also know that based on this, the newer diagnostic criteria have placed the prevalence of hyperglycemia to be anywhere between 24 to 27% in Southeast Asia. But we now have evidence to suggest that offsprings who are exposed to untreated GDM in utero, as diagnosed by the WHO criteria, are insulin resistant with limited beta cell compensation compared to offsprings of mothers without GDM. And the presence of GDM in the mother significantly and independently associated with childhood impaired glucose tolerance by increasing the odds ratio to 2. But no major correlation with impaired fasting glucose. And across the spectrum of the mother's blood glucose levels, exposure to higher levels in utero associated with increased childhood glucose and insulin resistance independent of maternal and childhood BMI and a family history of diabetes. So with this new knowledge, I hope all of our doubts have been put to rest about whether we should screen aggressively for hyperglycemia and whether we should treat values of 97 and 98 in fasting states in pregnancy. We have enough evidence now that not only do we affect this pregnancy outcomes, but we also could be improving the chances of better metabolic outcomes for the fetus in utero. So it was in 1989 that there was a St. Vincent's declaration made, which said that we should improve pregnancy outcomes of women with, of course, this is about diabetes, to the level of those in non-diabetic population within 5 years. And we are inching towards a reality where we should be improving pregnancy outcomes in mothers with GDM as well, and probably put in place methods, techniques, and processes to maybe even prevent gestational diabetes in mothers. So thank you so much for this opportunity, and I'm looking forward to questions. Thank you.